So again, we have the same disclosures or lack of. So in this study, we were looking at the therapeutic effect of Botox injections in patients with poorly compliant neurogenic bladders, and then going to compare clinical and demographic variables between patients who seemed to respond to it and those who didn't. This was an IRB-approved retrospective review of adult spinal myelopathy patients, spinal cord injury, myelomeningocele, who got 300 units of Botox for low bladder compliance, defined as less than 20 on urodynamics. That was refractory to medication. Outcomes were evaluated within 6 weeks, and the way we did this is we assessed symptoms based on incontinence episodes, frequency of catheterizations, UTIs, and if the patient felt that they were at least 50% improved, and this was also confirmed on their diaries, we would then repeat their urodynamics to reassess their compliance. And an objective improvement on repeat urodynamics was defined as an improvement of at least 5 milliliters per centimeter of water pressure. So a Botox responder was somebody who had symptomatic improvement and that was confirmed urodynamically, whereas a non-responder was a patient who didn't have symptomatic improvement, in which case they didn't even get repeat urodynamics, or those who thought they were symptomatically improved, but then on repeat urodynamics there was not that at least 5-point improvement. And then we compared the responders to non-responders. Overall, the majority in this case were male, about 50-50 myelomeningocele and spinal cord injury. All had tried multiple medications, and you can see on their pre-op Botox compliance was clearly low with a high end fill pressure, and about 50% had detrusor overactivity. So of the 27 patients, 14 or 52% experienced symptomatic improvement, but then only 8 of those 14 had objective improvement on the repeat urodynamics, resulting in an overall response rate of about 30%. And this shows the data for those 30%. Clearly, compliance improves from 11.5 to 24. The end fill pressure reduced, again, both statistically significant. The end fill capacity, though, didn't change significantly. When we looked at the preoperative variables between responders and non-responders, really the only significant difference was in the duration of their neurogenic bladder, with responders having a shorter duration compared to the non-responders. The presence of neurogenic detrusor overactivity trended towards being higher in the responders, but it didn't achieve statistical significance. And again, we see that the spinal cord injured patients, of the responders, most were spinal cord injured patients and fewer were myelomeningocele. So then in comparing those two groups, again, the duration of neurogenic bladder dysfunction was clearly lower in the spinal cord injured patients compared to the myelomeningocele patients, but and age higher in the spinal cord injured patients, but otherwise no significant differences between the groups. So in conclusion, Botox injections appear to significantly improve symptoms and bladder compliance in about 30% of refractory neurogenic bladder patients. There was no difference between preoperative bladder compliance between responders and non-responders, but a shorter duration of their neurogenic bladder dysfunction seemed to be associated with improved responsiveness, which suggests the possibility that there's less fibrosis in those patients, resulting in that better response. Thank you.
Thank you. Peter.
Hi, Michael. Peter was here from Utrecht, the Netherlands. What you would think as a pathophysiology of reduced compliance, especially in the meningomeningocele patients, they were born with a bladder that never had the chance to develop in a normal way.
Of course.
So if you ask the question in the end that there is fibrosis, I would say in the beginning, yes, there is fibrosis. And that differs from the spinal cord injury patients that are born with a normal bladder and then the innervation is damaged in the course of their lives. So they have a good bladder, that is, the innervation is. My question is, what could you possibly think is the mechanism of action of Botox in a fibrotic bladder?
Honestly, I don't know, unless there's still some residual muscle contractility that can be improved by it. Otherwise, I can't think of it.
So did you separate out the patients, one way or another, with meningomeningocele that had some kind of contractility or some kind of overactivity? And is that...
I see your point. We did not.
And would your message be, if there is a lot of fibrosis, there is no hypothesis whatsoever how Botox could affect?
That's a great point, and we should do that. If that turns out to be the case, and you don't, then perhaps that is the right message, that if there's clear-cut fibrosis, don't waste your time. We'd have to look at that, but that's a very good point.
I would think that's a sensible message.
Sure.
Yeah.
Very good. Thank you very much.